Hi, I'm Tom Buchholz. I'm a radiation oncologist who practices at Scripps MD Anderson Cancer Center in San Diego. I'm also the medical director of Scripps MD Anderson Cancer Program. Regional lymph node radiation are an important component of some cases treated with mastectomy and some cases treated with breast conservation. Again, when we're thinking about radiation treatments, it's important to define the targets. For patients with N1mi disease, usually they're in a very favorable category. And commonly, you're describing a situation in which the patient was found to have N1mi disease on the basis of the sentinel lymph node surgery. Most patients who have N1mi disease, when they present to their doctor, they don't have palpable, clinically palpable axillary lymph nodes. And if they have an ultrasound of the axilla, it's too small of a focus to be seen with radiographic studies by clinical examination. So the vast majority of patients with N1mi present with a clinical N0 axilla and have a sentinel lymph node surgery and have just this small foci of additional disease. If those patients are treated with breast conservative surgery and have a sentinel lymph node, then that's a situation where I feel it's easy enough to include the level 1-2 axilla in the same fields that I'm going to be treating the breast. And I don't see much in way of downside with respect to increased toxicity. It doesn't increase the cost of treatment. It really doesn't increase the short-term or long-term toxicity of treatment. And I know that there's a small but real possibility that there could be additional axillary disease, so I say, why not treat it? If that patient was treated with a mastectomy and a sentinel lymph node, that's a more challenging situation. I had previously referenced the fact that in the Z11 clinical trial, which was a breast conservative trial, who had predominantly favorable disease characteristics with a small number of positive sentinel lymph nodes and favorable biology and early stage primary tumors. Even then, the rate of positive lymph nodes, if you did a completion dissection, was up around 24%. Now, in the setting of N1mi disease, it's probably lower than that, but it's not 5%. It's probably somewhere in the range of 8 to 12% or so. And to feel as if that's going to not receive any local regional treatment if we don't do any additional surgery or any additional radiation becomes a real quandary. The standard of care still should be to do additional axillary treatment of some kind in the setting of mastectomy. So ironically, if a patient's treated with breast conservation, they might not be recommended to undergo an axillary dissection. But if they're treated with mastectomy, maybe they should undergo an axillary dissection because that could potentially preclude the need for radiation. So that's why I always argue for patients are better served by treating with breast conservation than being treated with mastectomy, because the radiation actually covers a relatively larger volume than is covered by the traditional surgery, and you could potentially avoid axillary lymph node dissection.